Next up, we have Lynne Wolf. Lynne is a dear personal friend, and she's also a professional colleague, and I think probably the most knowledgeable person in the world on my son's disorder. She leads the natural history study at the NIH on it. In fact, it was a conversation with Lynne many years ago in the atrium at the clinical center, which led us to identify one of the therapies that Bertrand is still on to this day. But that's not why she's here today. She's here because as an investigator in the Undiagnosed Diseases program, she probably has a world record in the number of diseases discovered. Obviously in collaboration with an amazing team yesterday. And I was struck by Mark Fishman's talk yesterday where he talked about the importance of extreme phenotypes. And we're very lucky to have Lynne here, who's probably spent much of her professional career finding them. So with that, thank you, Lynne.
Thank you. So this is a really important question, and it's interesting that we're having the discussion at the end of this really interesting meeting. So thank you, Larry, for inviting me. It's my first time. I've spent a chunk of time meeting lots of people that have been here previously. So let's hope I can expand your knowledge a little bit more. So prevalence of rare disease is actually not as rare as we might think. So about 1 in 1,500 people in America and about 1 in 2,000 in Europe is what the prevalence is expected to be. And that translates to the fact that a lot of our rare diseases are actually quite common. So 1 in 10 US citizens across the lifespan will be impacted by a rare disease. Most of them are genetic, and many of them remain undiagnosed for years. So yesterday we heard a brief presentation about a rare lysosomal storage disease, GM1 gangliosidosis, and the average distance between the time of first symptom and the time of diagnosis is about 7 years. That is crazy. It gives you very little time to make any kind of a meaningful intervention before those children die. So we really need to do better. Many of the rare diseases continue to be discovered almost on a daily basis, and we really need to characterize those very carefully. It pushes science for common diseases, it pushes us forwards for therapeutics, and it changes the way those families live. So for any of you that have family members or know anything about living with rare disease, these people have this incredible group of stakeholders that want to do research and want to give them treatments and want to learn more about family interactions and social media contacts, and it just becomes overwhelming. And at the same time, there is immense isolation and loneliness and feeling alone in your struggles. And that's something that I see in my patients a lot. So the importance of studying rare disease, I break down into these 5 categories. So what do I or my child have? What is my diagnosis? Or sometimes it's just a name to give closure to a really horrible experience. And why did it happen? So what is the genetic basis? What's the mechanism of the disease? What is the cell biology? And amazingly, we live in a time now where our patients are incredibly smart and they're doing a ton of their own research. And very often they come to you with incredible understanding and insight that you don't have at the time you first meet them. And you sometimes have to catch up. What will happen now? So in the old medical terminology, we would say prognosis, but really in this day and age, it's way more important for us to identify the natural history. So you can't start studying a disease that started 7 or 8 or 10 or 12 years ago and have a really good idea about when should you make an intervention. We really need to identify these diseases as early as we can, and we need to characterize them fully and follow them for a fairly long chunk of time to really anticipate all of the needs that that patient or family is going to need over time. Is there a treatment? So one of the things I learned from Matt is treatments are not always cures, and they're not always medical. So a lot of the things that I work on with my patients and families has absolutely nothing to do with curing their illness, but really is focused on quality of life. What will happen to other family members? So this is really important, because if you are working with a family who has a first child and they want to have more children, then you really want to try and give them a different bit of information from a family who's done having their children, but they're worried about their brother or their sister who is having kids, or their oldest child who's getting ready to have their own kids. So these are really important questions that we have to dig deep to answer. So if we consider diagnoses and closure, I'm going to tell you a couple stories. So this is an 8-year-old we saw in 2012. If you look at her in her wheelchair, this is her natural posture. So she was so weak that she could not hold her head up, and notice the positioning of her legs. She was starting to develop some contractures, and she really couldn't do anything for herself. And yet she had this incredible smile and just wonderful, engaging personality. So the symptoms that she had were upper-gaze palsy, optic nerve atrophy, cerebellar atrophy, truncal hypotonia, a nerve problem with her peripheral nerves, which probably accounted for some of the leg positioning we were starting to see. But even more sad was that she was losing skills. So this was an 8-year-old who had been going to school and playing with friends and talking and going to birthday parties, who now was wheelchair-bound and essentially nonverbal. So her parents were also concerned because she had an older sibling that appeared to not be affected, but they had no idea what would happen over time. So we actually did make a diagnosis for her, and that diagnosis was a brain iron accumulation disorder that we talked a little bit about yesterday, caused by a mutation in PLA2G6. Turns out she has 2 mutations. One of them was well known, but one of them was never seen before. So we had to prove causation. So this is the abnormal dark area that you see deep in the brain that is characteristic of these types of disorders. We subsequently worked with many scientists to describe the causation of this mutation, and subsequently identified that it caused a Golgi morphology problem that led to the neurodegeneration, because this particular gene encodes a phospholipid that is critical to Golgi formation. And it turns out, although this is a very old slide, there's about 14 or 15 of these disorders now, and so we used to call them the infantile neuroaxonal dystrophy, but we now know that they can occur across the entire lifespan. So you can diagnose patients with some of these disorders in their 50s or even later, and they are all terminal. It just takes a different amount of time for them to become terminal. So in this case, we gave the family a name, we gave them closure, and we reassured them that their other child was not going to pass the disease on or develop it. The next family is a very interesting family that I still actually stay in touch with, even though they've been diagnosed probably 7 or 8 years. So we saw this family of 4. Within the family of 4, 3 of the children, the 3 oldest, presented with the symptoms that you see there. And we identified mutations in this gene ERCC6. This gene is a DNA excision repair gene, but it causes Cockayne syndrome, which is a premature aging disorder. But unlike some of the progerias that you may have heard about or seen in the news, rather than killing the patients at a very early age, these patients can live into their 20s or their 30s. But they have an aging phenotype, so they continue to have bone problems and vision problems and gait problems and weakness. What was the most remarkable, though, was that because the 2-year-old youngest sibling, who is not affected and not a carrier, was below the age of the first symptoms of the other 3, we saw all 4 of them, and we assessed all 4 of them at NIH. Something that you can't do in academic medicine, right? Nobody really evaluates an unaffected, non-symptomatic patient. But in this case, we were able to do that. And if you look at this developmental screening tool scores, you can see that this 2-year-old outranks her older siblings who were progressively getting worse with age as far as their cognitive and adaptive and motor skills. It was really, really profound that we were able to find that. And the family was so relieved because they've been able to put some incredible resources around the older 3 siblings. And the youngest sibling takes care of her older siblings. She makes sure they eat and that their shoes are tied and that they have coats before they go to school. It's really quite an amazing thing. Then there are diseases where you find a totally new mechanism of disease. And this is actually fairly new. So there is a skeletal dysplasia, well described since 1982, called Saul Wilson syndrome. But in 2018, in the Undiagnosed Diseases program, we identified this very adorable redheaded little guy had a mutation in COG4. And COG4 is a glycosylation gene, but it had only ever been seen as autosomal recessive. So 2 changes in the gene cause a neurodevastating early disease. And this kid was cognitively normal. In fact, all of these patients have the most incredible senses of humor that I have ever seen. But they have huge health problems. So they have problems with intrauterine growth retardation. They have delayed growth and severe short stature, so that the adult height is about 3 to 3.5 feet tall. They have dysmorphic facial features. So if you notice, they all have very broad, high foreheads. When they're little, they have very prominent forehead veins. They have some narrow noses and little pointy chins. They have congenital cataracts. They have some retinal pigmentary changes that lead to night blindness. They have a sensory neurohearing loss, but they also have a conductive hearing loss because along with the skeletal dysplasia, their ear canals are very, very little. They have immunologic problems, including congenital neutropenia, so they have trouble fighting off bacterial infections, subsequently having frequent ear and respiratory infections. And then they have a significant skeletal dysplasia. Typically, they're born with club feet. They also have a unique odontoid hypoplasia, so the upper part of their neck where the skull and the spine join, and that can be very problematic. You can actually, dislocate and paralyze yourself with that. And they have a severe progressive osteoporosis that has led to most of the adult patients now needing joint replacements. And interestingly, the skeletal findings were the only things that had previously been described in Saul Wilson, and all of the other problems associated with this syndrome had not previously been described as fully as we were able to do. So here's what their hands and their feet look like. So they have these very, very short fingers and very short nails. They almost look like the tips of their fingers have been cut off. And then even after multiple surgeries, sorry, their club feet continue to be a huge problem. So imagine trying to walk with these. So they have special orthotics and special shoes, and some of them do have to wear crutches. So we had this one COG4 mutation, and we had a well-described skeletal dysplasia, and then we characterized 14 patients with all these other symptoms. And so then we said, okay, so is this COG4 change really doing something? Well, it turns out it's a de novo dominant that has a gain of function that disrupted vesicular trafficking between the Golgi and the endoplasmic reticulum. So, if you remember your cell biology from junior high or high school, you have your endoplasmic reticulum and your Golgi, and normally what happens is there's a lot of retrograde protein sharing between these two, and there's lots of convoluted areas for different proteins to move back and forth. In these patients, their Golgi is stacked very tightly, and it's very, very small compared to controls, and so it does not participate in the normal protein retrograde transport as we would normally see. And that particular phenotype was recapitulated in an animal model, the zebrafish. So we know that that was really the cause of this disease. So relatively hot off the press. And then the next question is there treatment? And, you know, we had a discussion earlier about very seldom do you find a new disease and say, I can treat that. But we actually had that experience. So this is a little 5-year-old who came to the Undiagnosed Diseases program with severe seizures and mild delays in fine and motor and speech. And he had this very unique anemia, dyserythropoietic anemia. So his bone marrow was hypoplastic and really not making all of the cells that it should have made. And he did not have iron depletion. He had splenomegaly, and he had a mild sensory neuropathy. And he was identified as having 2 changes in a gene called CAD, and they're both novel, so they've never been seen before. And in fact, he was the first case of ever being diagnosed with this particular disease, so a brand new disease. 25% recurrence risk was quoted to his parents, and he was their first child, and so they actually have subsequently had a second child who is not affected. So in this case, the mechanism of disease was not expected at all. So this trifunctional protein that CAD encodes is at the very beginning of the pyrimidine synthetic pathway. And so blocking everything downstream causes a deficiency of uridine. And uridine is critical to all the activation of the UDP-related sugars that are critical for glycosylation. So he actually presented with biochemical glycosylation abnormalities because every single one of his UDP sugars were downregulated. So this is a case where an enzyme in one pathway is actually demonstrating biochemical symptoms in another pathway. And it's completely treatable. because Ziridan, triacetyluridine, is on the market to treat a pyrimidine disorder called hereditary orotic aciduria. And sure enough, when we treated him, his seizures disappeared, and so did his anemia. And subsequently, there's been a whole bunch of new patients around the world identified since we published our paper, and it is now a well-known cause of seizures that are completely treatable with uridine supplementation, and they don't need seizure medicines. And there's a few patients now with this same disorder, but mutations in a different place in this gene, that have a immunodeficiency phenotype that also seems to be rescued by uridine. So the importance of identifying rare diseases: we discover new diseases, and then we need to better characterize them for the full spectrum of the disease. Because if you find just one of any new disease, you have no idea whether that is the most severe phenotype or the most mild phenotype or something in the middle. And you really need a lot more than an N of 1 to know that. There is always a possibility of treatments, and we have to think about that any treatment for a rare disease sometimes is very useful in common diseases. So right now, there's a lot of advertising for treating hepatitis B and hepatitis C. We're using glucosidase 1 inhibitors for that, and glucosidase 1 is a enzyme that's deficient in a glycosylation abnormality. And the reason that it works to treat encapsulated viruses is because once those viruses get into a cell, so a hepatitis virus will invade a cell, it has to make a capsule that is glycosylated to get out. But in the glucosidase 1 deficient patients, they can't ever infect other cells. They can't make the capsule. They can't get out. And so we've turned that into a medicine now for more common diseases. So you can prevent the infection of encapsulated viruses by impacting their ability to make their envelope. So this is important. Challenges is we need to share our data, and scientists are really pretty secretive. You know, we don't like to share our data. We like to keep it in our own labs, in our own filing cabinets, between ourselves and our patients. But if we're going to really do service, we need to open our closets, we need to open our labs, we need to share our specimens, and we've had some discussions about that. So challenges. Patient privacy is a huge challenge, and it's a challenge for us, but our patients don't see it as a challenge. In fact, our patients are challenging patient privacy regulations because they want their information out there. They want us to share, and so we can find more patients and find more treatments. Time associated with collecting and reviewing relevant data in academic and in research settings is huge. So the top picture is my fearless boss, Bill Gall, who at the start of the Undiagnosed Diseases program in 2008 actually looked at every piece of paper on every single patient that came through the door. He can't do that anymore, but he did when we first started. You have to also think about academic credit and intellectual property, because in academia, we're all judged on how many publications did we put out in any given year? What are the talks that you've given? You know, how else are you, being productive and supporting your institution? There's multiple issues around structured file sizes and formatting. There's laws that vary state to state, country to country, and there's language and basic science translation problems. So the Undiagnosed Diseases program went from just being in NIH to across the United States, and now we have multiple international sites. And so we needed to figure out a way, at least across that network, and use it as an example for other sharing opportunities. How can you make this successful? So data sharing tools have really come to the fore in the last few years. Goals of data sharing, for me, the most important is identifying additional cases to build a cohort that is a substantial enough cohort that you have a diversity of phenotype and genotype presentations and biologic specimens. And you also want those cohorts because families get an incredible amount of support, and you eliminate that initial isolation in rare diseases when you connect families with other families with similar disorders. And then, of course, you want to identify the clinical and the research experts to explore disease causation hypotheses. And so someone at this meeting talked about the importance of yeast models. So interestingly, some of our research experts for rare diseases turn out to be our colleagues that are working with yeast or animal models that never thought there would be a human disease. So case in point, there's a channelopathy caused by a mutation of SLC12A2, and that particular Saul eukaryote has been studied for many years by a researcher named Eric Delpier at Vanderbilt. And we identified 2 patients with mutations in that Saul eukaryote. And so imagine his surprise when we called him up and said, "Would you like some human cells to add to your yeast?" And he was like, "Bring it on." And he has been our collaborator now, working with the patients and expanding his own work for that gene for quite a while. Open data sharing is really patient-driven, and I'm sure that many of you guys have been exposed, maybe even have participated if you have family members or if you're working with rare diseases. So the person with the illness or the parent of the child with the illness is the person that enters the data. And so any of the contributors get to look at the cases, and they can contact other participants. Now, it depends on the story that's told by the family member, right? So it's not necessarily objective, testing by blood test or a diagnostic test or a physical exam finding. It's really the story as it's lived by that family. And so the family really can be very open in their sharing, and frequently they'll put photographs. If they do have molecular data, they'll put molecular data. But very often it's really just the story of their family. And it's important, and it's really helpful, but it isn't always what a scientist or a physician might need to move forward. There are some closed data sharing programs too, and in those programs, the submissions can only be edited by the submitter, i.e. a scientist, a clinician, and generally there's a little bit of guarding about what information is put out there, and we have to use a common language or we don't know what we're all talking about. So the general common language, which I'll talk about a little more in a minute, is the human phenotype ontology, or HPO terms. It doesn't usually include personal information of the patient, right? Because we want to protect privacy, but in the protection of the privacy, we take away some of the personal story that could be really important. And the site allows users to control access to submissions. So you really don't always know what else is maybe available when you're looking. Ideally, I'd love to see something in the middle, and I think we're moving more towards that. So the human phenotype ontology is a monarch initiative, and it was really developed to be a standardized way to describe symptoms that we see in our patient across languages and countries so that you could make a reasonable computational comparison of a specific symptom and say, we're all talking about the same thing. And if you look at this particular example, you can start with a very general comment or description like abnormality of skull size, and you can make it more and more specific so that you can then describe, is this a child with a congenital microcephaly, like you might see in a Ziki syndrome? Is this a progressive microcephaly? Is this a postnatal microcephaly? Because we know if you're born with a small head or you get a small head after birth, that's a different differential. And so HPO terms are very, very helpful. And then probably the most helpful thing for data sharing right at the moment is matchmaker exchange. And I don't know if anybody in this room has used it. It really kind of tries to do all the things that I would love to see between MyGene2 and Phenome Central. It tries to tap as many different sources of data that is out there so that you can do a much better job of matching cases, especially if you have an N of 1 to a different institution or to a different scientist, and then you can communicate and really work on a collaboration and figure out if what you have is the same thing. And so I think that what we've learned in the Undiagnosed Diseases program is that you can make diagnoses on an N of 1, and you can find some very exciting new diseases and some exciting cell biology, but you really can't make the impact you can make if you're really sharing it broadly and finding a lot more patients. And you have to partner with your families, not just with other scientists, to really strengthen what we can do, especially when it comes to rare disease. And with that, I will just acknowledge that we have a very huge team at NIH in the Undiagnosed Diseases program, and if anybody has questions, I'm happy to answer them.
Thanks. That was really a great overview of a lot of programs that I didn't know about. I can see the great benefits to a lot of these families and just putting a name on something, and that's a huge benefit. How often are you also able to identify a therapeutic?
So not as often as we'd like, for sure. My best guess is probably somewhere around 1 or 2%. So this is an interesting thing for those of you in the group that are really doing a lot of genomics. You know, the Undiagnosed Diseases Network at this point has a lot of resource at its disposal. And even with everything that we can look at, genomics, RNA-seq, transcriptome, metabolomics, whatever, there's about a 25% hit rate for making a diagnosis. So there's a lot of work still to be done. And then to find good treatments for any of those rare diseases, that's even harder because you have to prove causation of the disease, you have to understand the cell biology exquisitely, and then you have to partner with someone to make a therapeutic agent for you if one doesn't exist that you can retool. So there's a lot of work to be done.
Thanks. That was a lovely talk. Thank you very much for putting that all together. I want to ask about the data sharing components in that part, because I don't think it's just psychological. I don't think it's just the resistance of the researchers. There's a lot of work required to characterize things in HPO terms, to make data available. You mentioned files and formats, but that's really just the beginning of trying to make data that's shareable in a way that researchers can use. So will you talk about some of the things that NIH and the UDN have done to support that kind of data sharing work, and what's been effective and what's been less effective?
Yeah, so that's a really great question. So the primary focus right now for NIH has been a lot of education and learning. So I think the scope of the problem, you're right, it is not just personal or institutional resistance or patient privacy issues or regulations, but a lot of it has to do with the fact that different places organize their data in different ways and have collected very different data than maybe another institution. And so you have to figure out what you have and how you can work with it. I think the scope of the problem is really quite huge, and I don't think anybody really knows what that is. And so NIH's approach so far has been that we are going out, interacting with the UDN sites, but with also other academic centers and investigators to learn what is it that you do at your institution, what are your resources and supports, how can we get those to interact with the UDN network, since that is a well-established network. How can we tap investigators that didn't know about certain tools? How do you make sure those tools get recognized and utilized more broadly? And so I think at the moment there's a lot of investigation to identify the true scope of the problem to push it forward. So not a good solution yet, but it's coming.
Tim Yu from Boston. Lynn, just congratulations to you and the UDN team, to Matt as well for everything you've done for UDN, and to Bill for his leadership on this project. So I just wanted to say that publicly as a rare disease researcher. It's fantastic work. I was just wondering whether you might want to comment on what the NIH is doing, and this is a little bit of a follow-up to your question, to generalize this work. We've set this network up to sort of lead the way and show how this could be instituted in many places.
Right. So, yeah, that's so bad. It is so much work. So the UDP was just at NIH from 2008 until 2015. And then the Common Fund put millions of dollars up available for grants to extramural programs around the country. And we identified 7 extramural sites at that point, including sequencing cores, metabolomic cores, et cetera, outside of NIH, because I think everybody felt like it was really important to spread the wealth. We ended up just this year in September going into phase 2 and expanded now to fully 12 clinical sites in the United States that are somewhat funded. They're not 100% funded, but they're subsidized by NIH to get the ball rolling, with a big emphasis on sustainability over the long haul. And then Dr. Gall's primary goal this last few years has really been to get the Undiagnosed Diseases International Network up and running. And so I think that probably the most important thing that we're trying to do is foster collaborations and communications and figure out who are potential collaborators that we haven't tapped yet, who are the basic scientists that can help us solve some of our unsolved cases, are there innovative research methods that are coming, to the fore that we've not utilized yet. So we go out, we do a lot of education and talking, and bring back information, and then we try and, just keep moving information forward.
Thank you very much for your presentation. Is any data being collected on the psychosocial stressors for patients as well as family members?
Yes,
And
actually.
what's being done with that? Because compassion fatigue, burnout, secondary traumatization.
So obviously the undiagnosed diseases clinicians can't do all the work. So we have, as you saw in one of my presentations, we have We have a good neuropsychology team working with us that helps us in various ways with formal testing and identifying resources for families that they wouldn't otherwise have access to. But more importantly, we have a collaborator right now who is an investigator who's doing telephone interviews with all the families in the Undiagnosed Diseases program, sort of like a week or so before they come, and then during the week they're there, and then a follow-up, I think, about 30 days later. But she's following that with doing blood draws of cortisol and other stress hormones in the family members. So that will be announced, you know, whenever she's done with her data collection. But yeah, the psychosocial stress of families with undiagnosed or very rare diseases is definitely something we want to look at aggressively, and it is being done.
All right. Well, thank you, Lynn.
You're welcome.